Hi, everyone. Welcome. Josh, welcome. Welcome to this month's TALAHour. Thank you for being with us today. Just so everyone knows, and I'm sure they saw it pop up or heard it, this is being recorded. Everyone that registered for today's TALAHour, and we have a lot of people that looks like that registered that weren't able to make it. Everybody that registered will get sent the link and the presentation later on this afternoon when I get that in. Also, if you have any questions today, please use your chat function. And depending on where we're at in the presentation, if I can, if we have a pause, I'll ask Josh the question. If not, we'll wait until afterwards and answer all questions then. And with that, I want to welcome Josh again. Josh Allen, he's an RN. He's a principal with Allen Flores Consulting. He's been in the senior living space for over 25 years. They've been an industry partner of TALA for many years, and for that, thank you. And he's been very active in some of our committees and helping with some policy discussions. And with that, Josh, I will turn it over to you if you want to do any more of your bio, or if you want to jump us right into it. I do have to make you a co-host though, so you can control your screen. You are
All
now a
right.
co-host. Take it away.
Thanks, Diana. Appreciate it. Thanks, everyone, for carving out a portion of your Friday for us. Hopefully you can see my screen okay. Yeah, I won't bore you with any long bios or intros. I think Diana mentioned the key points. I'm a registered nurse. I've worked really my entire nursing career in senior living. And we really appreciate our partnership with TALA and the chance to be here today to talk with y'all. Our topic, as you know, is UTI management in assisted living, which, let's be honest, isn't exactly a new challenge that we're having to deal with. It's something we've been aware of and had to manage in our residents throughout our careers and our time in senior living. But I got to tell you, to just step back for a second, I don't know about you guys, but to be able to refocus on some of the basics, if you will, we're no longer talking about COVID on every single webinar. I think it's great. Really getting back to our strengths as senior living providers, really looking at ways to impact our residents' quality of life. And I'm sure, like many of you, we really, post-COVID, as we've been dealing with rising acuity, like I'm sure many of you have, and really trying to find ways to address that acuity in our resident population and bring in partnerships to be more effective care providers. I think as an industry, we're still kind of figuring out where we fit in the healthcare spectrum. But I don't think it's quite the way we used to look at it. An older adult would be independent, they would live in their home, and then eventually they would move into assisted living, and then eventually they would move from assisted living to skilled nursing throughout their progression. I think we're much more now sort of spokes on a wheel as opposed to this continuum. So our residents really view our assisted living communities as their home. This is where they're going to live for the rest of their lives. And we work with all these other various providers and settings to make that possible. And UTIs, while not necessarily kind of new and sexy and exciting, these are big contributors to poor outcomes for our residents. They are big contributors to hospitalizations. They can contribute to falls and just a general decline in their health outcomes. So I think really using this as an example of how we lean into those other resources and partners to be more effective as part of that healthcare solution, I think is a good place for us to start. So we'll try to cover a number of things in our hour that we have together. We'll talk about identifying UTIs, the prevalence in seniors. We will, sorry, I'm doing a little bit of technical rearranging here on my computer. We will talk about complications, and then really want to focus on these last two bullets, of course, which is the prevention and treatment of UTIs. How do we get better at managing UTIs in our residents? And frankly, a little more sophisticated. You know, it's no longer appropriate to just say, okay, my older adult is a little more confused, let's put him on an antibiotic. We really need to have a more targeted approach to how we're going to address UTIs in our residents. So let's start with some basics. I'm sure this all is familiar to everybody, but make sure we're all on the same page. What exactly is a UTI? As you know, it stands for urinary tract infection. And really, a UTI can be an infection in any part of the urinary system, from the kidneys all the way down to the urethra. Any part of that urinary system, if it's infected, that is by definition a UTI. Most common, of course, is UTIs or infections in the lower urinary tract. So we're talking the bladder and the urethra. Part of that is just simple anatomy. You know, if you think about bacteria getting into the urinary system, they're going to enter through the urethra, which is that small opening in your body where urine comes out when you go pee. So bacteria find their way into the urethra, they're able to establish and grow, causing that infection. And then from there, it will start to work its way up the urinary tract. Obviously, we would want to catch it before it gets much further. If we start to get into the ureters, which are these long tubes that connect the kidneys to the bladder, or certainly into the kidneys themselves, the infection can be much more serious, much more difficult to treat. So our goal, of course, would be to prevent them at all. But if an infection does occur, we want to catch that while it's in the lower urinary tract, which is by far the most common. To identify a urinary tract infection, we start with sort of recognized signs and symptoms. And we really want to be thinking, obviously, we're talking about assisted living today, so we want to be thinking about signs and symptoms in older adults. They are very similar to the signs and symptoms in a younger adult, but there is some sort of uniqueness to how UTIs present themselves in our residents. These are the signs and symptoms we should be watching for as identified by the American Medical Directors Association. And I do want to take a second to mention the American Medical Directors Association. They have a great consensus statement that they have published. I'll show it to you here. They have a great consensus statement that they have published on UTIs in post-acute and long-term care settings, which would include us, assisted living. If you've not read this before or seen this before, I would really encourage you to take a look at it. Again, this is the American Medical Directors Association. So this is an association for the doctors that work in long-term care. And obviously, a lot of that is a little more focused on nursing home, understandably, but there is still a lot we can learn and apply. And AMDA does a lot of work specifically on assisted living. So they've published and updated this consensus statement on UTIs. And really, we use this as our framework for how to approach UTI prevention and management in our resident population. So it's really going to be the framework for most of my presentation today. So again, it's a great resource. You can Google it. You can download it from their website. I would highly recommend you check that out. So these are the signs and symptoms that they recommend we look for in older adults. Pain or burning during urination, or what's known as dysuria. That, of course, is really considered sort of the classic hallmark sign or symptom of a UTI, painful urination. Blood in the urine, which, keep in mind, does not always present as, bright red streaks in the urine. A lot of times what you get is urine that is cloudy or darker in color. Sometimes it's described as looking like Coca-Cola when the person urinates. Pain or tenderness in the pelvis or abdomen. That's also sometimes referred to as suprapubic pain. So pain or tenderness, that's, think about it. It's basically where your bladder is. It's where that urethra is coming out of the bladder. So you have some pain or tenderness in that area. I would say this fourth one is one we definitely see as a red flag of UTIs in our resident population: new or worsening incontinence or urgency. So you have a resident who all of a sudden develops incontinence, or all of a sudden is having more frequent incontinence. I think this is a helpful hallmark for us to look at for a lot of reasons. One is we have to remember, of course, many of our residents, due to dementia or other factors, they're not very good at reporting their signs and symptoms. So they may not be able to tell us, hey, it hurts when I go to the bathroom. So that one is one that we can easily identify without the person having to self-report. Fever, chills, back pain, nausea, or vomiting. Those would be signs of a worsening UTI. That most likely means that the infection is moving up into those ureters, those tubes that connect your kidneys to your bladder. As it moves up, it's physically moving up higher up the abdomen. And those are actually located along your back inside of your abdomen. So it presents as these types of symptoms: back pain, flank pain, or again, fever or chills. We may also see increasing fatigue, which is generally a common sign or symptom of infection in older adults. Before I go on, there's a question in chat. Can you share the PowerPoint? Absolutely. I'm going to send it to Diana and team after we wrap up, and they will send it out to everybody else. I'll admit, I am a classic procrastinator. So I was putting final touches on this PowerPoint moments before we got started. So apologize we didn't get it out in advance, but we will definitely get it to you. Now, what about sudden confusion? This is amongst senior living providers or anyone who cares for older adults. I think we all associate sudden confusion with a likely sign of infection. And there is certainly some correlation there. And part of that can be, again, especially in an older adult who has difficulty communicating. Imagine if they're experiencing burning every time they urinate, or they're experiencing pain in their suprapubic area, or they're experiencing that back pain. That's all really unpleasant. And so it can sometimes present itself not just as sudden confusion, but even as behavioral changes. Again, particularly in your residents with difficulty communicating. However, as we'll see as we dig into the AMDA guidelines, we do want to be careful not to use sudden confusion alone as an identifying sign or symptom. Using sudden confusion alone is associated with overtreatment of UTIs and mistreatment of other infections. So what we should not do is just see a resident who's incontinent and confused and say, okay, they have a UTI, let's put them on antibiotics. It needs to be a more thoughtful approach in order to be effective. And we'll get into that. What about complications? Goes without saying, an infection's a bad thing. You probably don't need me to tell you that. There are a number of associated complications with UTIs. One is, of course, worsening infection. Remember that urinary tract is a continuous system all the way up to the kidneys. And the kidneys have a tremendous amount of blood flow going through them. Remember, the kidneys are basically like the filter to help get stuff out of our body. So if that infection goes untreated, it can become quite severe, even life-threatening. Other complications can include incontinence, as we've already talked about. Someone who can develop incontinence because of the urgency and the frequency of urination. One of the biggest potential complications we should be aware of with UTIs is falls. We work with an incontinence management group called Total Incontinence Management, or TIM, in many of our communities. They've made a lot of really interesting research available to us. One of them is some published studies that showed a 5 times increase in falls when a resident has a UTI. So it again, doesn't mean if someone falls, we should put them on an antibiotic. But it does mean if we're seeing increasing falls in a resident, especially one who has difficulty reporting signs and symptoms, it's something we should consider. Could this be connected? And sort of trying to play private investigator as we look at and putting all these pieces together. There's more incontinence, they're having more falls, they seem more agitated. All of that might be painting a picture that tells us we've got a UTI going on. Equally as important, if we do a good job of preventing UTIs, we can have a significant decrease in falls. And you don't need me to tell you that falls are a major risk amongst our resident population. They are, for instance, the #1 reason that senior living communities are sued is over falls. So you may not have thought, hey, by addressing UTIs, I'm going to help with my falls. But as you can see there, 5 times increase, you can have a huge impact. That same research also showed a 2 times increase in falls for incontinent residents without a UTI. So we know what UTIs are. We've pretty well established they're a bad thing. So what do we do about it? How do we approach prevention and treatment? One of the first things we can focus on is physical activity. And the impact, as you can see here in these numbers, is tremendous. One study showed a 53% reduction in hospitalizations for UTIs through increased physical activity. The same study showed an 80% reduction by increasing the physical activity of mobility-limited residents. Even simple things like helping them get out of bed and into a chair, helping them to transfer several times the day, helping them to turn and reposition in bed, an 80% reduction. Now, I feel like almost every webinar you ever get on, they're going to tell you to increase physical activity. It's good for so many things. It's good for gait, strength, balance. It's good for psychosocial benefits. You'll see improved cognitive functioning. But again, just simply getting our residents engaged, get them involved in activities, get them out of their apartment, get them coming down to the dining room. It's not rocket science. It's simple stuff. But if we really focus on that, especially in our residents who have been dealing with UTIs, we can see it, as you can see from those numbers, we can see dramatic decreases in their risk. I'm going to bring up a controversial topic now. It's Friday afternoon. Let's get our juices flowing a little bit. No pun intended, juices flowing. What about cranberry juice? For as long as I can remember, this has been sort of a home remedy for treating and preventing UTIs. And there has been some research in the general population on the benefits of cranberry juice to reduce the risk of UTIs. But I want to focus specifically on our resident population. There was one double-blind, placebo-controlled trial of 185 female nursing home residents looking at the role of cranberry juice and reducing UTIs. AMDA also cites in their paper a Cochrane systematic review of available literature on the impact of cranberry juice and UTIs in long-term care residents. You want to know what those studies found? It doesn't work. I'm sorry to tell you. In our resident population, the studies do not show that cranberry juice is an effective method for preventing or treating UTIs. Now, with that said, don't get me wrong. Drink all the cranberry juice you want. Help your residents drink cranberry juice if they enjoy it. But being realistic, the studies tell us it's not an effective way to prevent or treat UTIs in our residents. What is effective, we already said physical activity, extremely effective. So we should focus a lot of our priorities around that. What's also effective is good old-fashioned hydration, keeping the person hydrated. And there's a number of reasons for it, but the simplest one to think about is just the physical impact of hydration. So I don't want to make you motion sick here, but let me go back to that picture, right? So think of your urinary tract, your urinary system, right? You have the kidneys filtering all that junk out of your blood, turns it into urine, which travels down the ureters, collects in the bladder, and then it leaves the body through the urethra. Pretty cool system, right? Pretty simple. When you're not hydrated effectively, what happens to your urine output? Goes down, right? If you're not drinking as much water or taking in as much water, you don't have to just drink it, by the way. There's a lot of water in things like fruits and vegetables. But if you're not consuming enough water, the amount of urine you're creating is going to go down, right? Well, as you're making less urine, there's less urine flowing through this system, right? You have less coming through your ureters, you have less collecting in your bladder, you have less leaving through the urethra. So that just allows things to sit. And if things just sit, bacteria love it. When that system's just kind of sitting and not active, bacteria have a much better environment for their growth. You know, this is kind of a bad analogy, but think of like a gross, stagnant pond, right? I like to golf. Probably some of you like to golf. You ever been on a golf course and there's a pond with a fountain in it? The fountain's spraying water everywhere, and that pond's clean, and you can see through the water, you can see the fish and the turtles. And then you go to a pond where the fountain's broken. There's no water running through it. And how's that pond look? Not good. It's murky. It's got scum on top of the water. It's gross. You hit a ball into that pond and you say, I'm not looking for that. I'll just get a new one out of my bag. Well, you can kind of think of like that with your urinary system. If you're not drinking enough water to push things through that system, it's going to allow that crud to build up. And in this case, that crud are bacteria that lead to a UTI. So by just hydrating, you help to push fluid through that system, and you help to quite literally, physically flush the system out. Very simple idea. Now, one of the challenges, again, sorry for the, back to where we were. One of the challenges with hydration is just, residents who have a decrease in appetite, residents who maybe don't like to drink water. Again, you can find alternatives. You can find water in other ways, juice, fruits, vegetables. I hate saying Jello because it has such a bad stigma with long-term care and senior living, but there's lots of other ways to get water besides just drinking a glass of water, okay? But really focusing on that to ensure that our residents are properly hydrated. We also have to be careful that if someone becomes incontinent, what they often try to sort of self-manage by drinking less. I get it. I could see how they would arrive at that decision. Hey, if I drink less water, I'm going to make less urine and I'll be less incontinent. It is logical, but it's not good for you. So we want to focus on getting them hydrated, which means we also have to focus on good incontinence management for residents who are dealing with that challenge. Good incontinence management starts with, the basics. Keep the resident clean and dry, clean the resident from front to back. But what we've really been focusing on in our incontinence management approach as of late are the products. The product that the resident is using to manage incontinence. So if they're using a brief, if they're using a pull-up, if they're using pads, whatever it might be, we've really, over the last year or so, again, we partnered with Tim, Total Incontinence Management. There's other partners out there, but we really focused on having a good product in our communities. Over the years, I feel like what's happened in most senior living communities with incontinence management is we've really left it to the families to figure out the product. And so we end up with all kinds of stuff. Some of them, they go buy it at Costco and they bring it to the community. Some of them order it on Amazon and they have it shipped to the community. And the problems we find with that are a couple of things. Number one, the product they choose itself, the actual product, if it's of low quality, if it can't properly absorb that urine, what's that going to do to their risk of UTIs? Going to go up. Think about it. If you just flushed all those bacteria out in your urine, and now that urine sits exposed to your skin and your urethra, they're just going to crawl right back in. So having a good product that properly absorbs and keeps that urine away from the body while it's in the product is really important. Secondly is availability of product. This, I think, is one of the biggest challenges when we leave it to the family to manage it. They don't always bring us enough stuff. We probably don't want to admit this, but I'll bet we all have seen situations where resident A runs out of product, the family isn't answering their phone. What do your caregivers do? Don't tell anyone, but they go to resident B and they borrow a couple briefs. Never happens, right? That's never, ever happened in any of our communities, of course. But we want to make sure we have that a good product selected and sufficient quantities of product available. So we've been shifting away from allowing families to manage the product, and we've been telling them, we're going to do this for you using our incontinence management partner. And what we find is initially families are concerned about cost. So we've worked with our partner to make sure the cost is relative to what they might spend at, Costco or Amazon. but we also really take the time to educate the families on why a good product matters. You know, that it's worth spending the money on that good product. Reduction in skin problems, reduction in UTIs, better dignity for the resident. You know, there's a decrease in falls. I mean, there are a lot of benefits to focusing on that. And again, I know incontinence product is not like the new exciting, sexy topic everybody wants to talk about, but it's really important. And I think in a lot of our communities, we're not doing a great job of managing that. We have some room for improvement.
Josh, I want to follow up a little bit. How much pushback do you get initially? I mean, how often do you feel like you're successful? Because I can see families saying, no, I want to go to Costco, I want to go to Sam's, you know.
Yeah. We get a fair amount of pushback. It kind of reminds me of trying to get the family to use our pharmacy. Pretty similar challenge. The difference here is they've got money coming out of their pocket, whereas with the pharmacy, they probably don't. So the way we've approached it in states where we're allowed to do this, and we do this in Texas, we have incorporated it into our assessment, and I'm sure everyone uses different models. Ours is a points-based assessment for levels of care. We incorporated a points calculation if they are incontinent and don't use our product program. Similar to what a lot of people do with pharmacy. You know, you can use whatever pharmacy you want, but if you don't use ours, we're going to add, again, depends on your system, 10 points, 20 points on the assessment. And we don't do that to punish the family. We do it for the reality of, we found when we decided to look at this, and I'll be honest, our partner had to kind of drag me kicking and screaming. I was thinking, like, really, incontinence product? I have so many other things I'm worried about. But when we really dove into it, our caregivers were spending a tremendous amount of time dealing with this. We also found that a lot of our communities were losing money because they were buying product and not getting reimbursed. So we do get some pushback, but what we often find, honestly, it's like a lot of things, we get a handful of residents participating, and then they start talking to each other, or the families start talking to each other. And so usually it's a fairly slow ramp up. And then after 3 or 4 months, we've got, you know, a really high percentage of participation amongst our residents who are incontinent. And I think part of it is just an attitude shift of, you know, we don't expect the family to bring the plates and cups and forks and knives that our residents use. So why should it be different with their care products? And so we're just over time really shifting that attitude of, oh, your mom's incontinent, no problem. We can manage that. We'll get the product. Here's how this works. And I think you see, like, a year later that it's not even really viewed as anything unusual. But, you know, you bring up a good point. You'll get pushback for sure.
Yeah, definitely.
And we've leaned a lot on our partner to provide family education. They'll do family nights, they'll do webinars, they'll talk one-on-one with families, so that we're not, you know, sort of being a salesman for a particular product, and that's helped a lot as well. Okay, so we want to prevent to the extent we can, and really the primary focus is physical activity, hydration, incontinence management. Focus in those areas, and we're going to be pretty good at preventing UTIs. But even with all that, you know, all those efforts, there are still going to be UTIs. So let's talk a little bit about treatment. And this is an area where I think we need to, again, have a little bit of an attitude shift, that for a very long time, UTIs have been over-treated and inappropriately treated. Meaning, over-treated, we have a resident no symptoms, but someone does a culture and it comes back positive. Where do we see that? We see that in our emergency rooms, right? Resident gets sent to the ER for who knows what. They run a whole standard panel of tests. They get a positive culture back, and even though they have no symptoms of UTI, they start treating them. We also see ineffective treatment by not identifying which treatment is going to be effective for the particular bacteria that is causing their infection. So we really want and obviously we're not the ones prescribing treatment. I recognize that. But we really want to focus on a more thoughtful approach to UTI treatment. Quite often, a resident doesn't actually have a UTI. They have what's known as asymptomatic bacteriuria. Say that 10 times fast. Asymptomatic bacteriuria. What does that mean? There's bacteria in their urine, but they have no symptoms, right? So a positive urine culture, but no symptoms. This is estimated to impact as much as 50% of female residents, and I have a typo there. Let me fix it on the fly. That should say 30%, sorry. 30% of male residents, meaning if you took every resident in your community and you did a urine culture on every single one of them, 50% of your female residents who have no symptoms would come back with a positive urine culture. That does not mean they have a UTI. Again, think about the anatomy we're talking about here. Your urethra is opening through the skin, essentially. There's bacteria all over the place. You got bacteria all over your body at all times. It's very normal. And so identifying some bacteria in a urine culture without symptoms should not be treated as a UTI. And far too often it is. Again, not so much in the community because you're probably not running urine cultures for no particular reason on your residents. But we see it a lot when they go out to hospitals or perhaps long-term care, skilled, and they're identified and being treated as having a UTI. And the problem with not having an effective treatment and appropriate treatment is you're going to dramatically increase that resident's risk of things like C. diff. And when someone's on a broad spectrum antibiotic, that's where we see C. diff infections pop up. As crazy as it sounds, having bacteria in your body is actually a good thing. It's part of the equilibrium in your body. We have what's known as our normal flora, meaning all of us have bacteria in our bodies all the time. And they actually help to keep everything in check. If you take a broad spectrum antibiotic, it wipes out the normal flora and lets other things creep up, C. diff being one of the most challenging. It also, over-treatment or inappropriate treatment, increases that resident's risk of drug-resistant bacterial infections. Overuse of broad-spectrum antibiotics is essentially the reason we have multi-drug resistant organisms. You think of things like MRSA or VRE. So in the AMDA guidelines, they have sort of a decision tree for UTI treatment. They have one for residents without a catheter and one for residents with a catheter. I'm going to put these on the screen. They're a little overwhelming to look at initially. But again, you'll get a copy of the PowerPoint. You can kind of take some more time to absorb it. So this first one, this decision tree, is for a person without a catheter. And you can see at the end of the decision tree, you get either to prescribe antibiotics or you get no antibiotics. So we start up here at the top. I'm just going to walk you through this. There's no quiz. You don't need to memorize this. The key point I want you to take away from these two slides is we don't just treat because they come back with a positive culture. The treatment should be driven by symptoms. So we suspect a UTI. The person has a recent onset, and they use a lot of medical terms in here. Dysuria, that's that painful urination. So they have a recent onset of pain when they urinate, urgency, frequency, incontinence, or visible urethral purulence. In other words, discharge from the urethra. So if they're experiencing any of that, the answer is yes. And so we go on to the next question. Do they have any systemic signs or symptoms? 2 or more of the aforementioned symptoms. So again, I don't want to give you too much whiplash here, but think back to these symptoms, okay? 2 or more of these symptoms. So if we suspect a UTI because of any of these issues and they have 2 or more symptoms, so the answer is yes, then boom, antibiotics are prescribed. If they do not have 2 or more of those symptoms, but they do have pain, either suprapubic pain or back pain, they should be treated with antibiotics. If they don't have 2 or more symptoms and they don't have suprapubic or back pain, they should not be treated with antibiotics. And again, I recognize most of us on this call are not the ones prescribing treatment. The main point I want to drive home with this, as I said, is that treatment should not be based on a culture alone. It should be based on looking at signs and symptoms in a very thoughtful way. This is also great information to share and discuss if you have, most of you probably don't have medical directors, but a lot of us do have primary care partners, nurse practitioners, physicians, physicians' assistants that come into our communities. And these are conversations we should have with them. You know, how are we approaching UTI treatment? Because we don't want to overtreat UTIs. We want to be more targeted. This particular slide is if the person has a catheter. You can see it's quite simplified. If we suspect that they have a catheter, do they have at least, or if they have a catheter and we suspect a UTI, it would be at least one of the following: fever, shaking chills, or clear-cut delirium, meaning sudden confusion. So if we see any one of those, then yes, they should be treated for a UTI. You'll also notice that in these boxes that talk about treatment, it talks about obtaining a culture so that we can do a specificity of treatment. And again, I know that that's the prescriber's concern, but that's the sort of thing we should be advocating for with our residents. Let's get away from these broad spectrum antibiotics and let's focus on identifying which treatment is going to be effective for this particular bacteria that they've been infected with. Now, finally, to execute on all of this, we need partners. As I said in the beginning of our hour here. These are the partners that we really focus on in our communities, not just for UTIs, frankly, for lots of reasons. But as it relates to UTIs, these are powerful partners. We've already talked a little bit about having a partner for incontinence management, particularly focused on products. Having a primary care partner. Having on-site primary care so that we're not sending people to the emergency room. If you send them to the emergency room, I would bet you my next paycheck they're going to get treated for a UTI. So by having on-site primary care, we can prevent things getting to that point, allow the resident to stay at home in our community, and frankly, have better treatment because they're going to think through those pathways that we were just talking about. Along with primary care, we need a lab partner that can help us to obtain those specimens, help us to arrange for cultures, and help us to identify the appropriate treatment for the bacterial infection that this resident is suffering from. We lean on a physical therapy partner. Physical therapy partners are going to help us with that increased activity that we were talking about. If we have a resident with mobility limitations and we're trying to find ways to get them more active, in addition to your own activity programming, if the person is a candidate for physical therapy, that can be multiple times per week that they're being engaged in physical activity without burdening your staff. It can be done by your PT partner. Lastly, technology partnerships, I think, present an interesting opportunity. In a number of our communities, we partner with CarePredict. I'm sure many of you are familiar with CarePredict. It's basically a wearable device. Both the staff and the resident wear a device, and it does things like nurse call, but it also monitors the resident's activity patterns. And using its algorithm, it can identify potential UTI based on a change in their activity pattern. So, for example, are they going to the bathroom more often? That would be one real telltale sign, right? That's frequency. And so the technology can actually alert us to those changes, particularly when we have residents that may not vocalize those things to us. In one study that CarePredict did with a provider, they saw that by using CarePredict, they were able to resolve UTIs on average within 15 days, compared to on average 24 days for residents that were not using CarePredict. And that mainly had to do with the earlier identification. Pretty cool stuff. But again, I would say, let's think take-home lessons from today. Number one, a more thoughtful approach to UTI treatment. A positive culture does not in and of itself mean they have a UTI. There should be the presence of symptoms, as AMDA lays out in their consensus statement. Number two, focus on prevention. And again, it's simple stuff. Physical activity, hydration, and appropriate management of incontinence using good products. And then third, engage these partners. I would really look at this list as a checklist of the partnerships you should have in your communities, not just for UTIs, but again, going forward over the next 3, 5, 10 years, as we figure out where senior living fits into this healthcare spectrum, as Medicare is shifting away from fee for service and focusing reimbursement on outcomes, we have a real potential to be a strong part of that. And these partnerships are critical. I would also say that when we talk about partnership, it doesn't mean a casual relationship. Having a very clear, formal relationship where these partners are on site in your communities on a regular basis, whether that's daily, weekly, monthly, depending on the nature of the services. Well, we are getting close to the end of our hour. Wanted to save a little bit of time to see if anyone has any questions, and then I'll turn it back over to Diana.
Any questions out there? Y'all can use the chat function, or if you want to do a raise your hand. like you covered everything, Josh. That was really informative.
Thank you.
Thank you. I enjoyed that. I want to thank everyone for attending today. We really appreciate it. We've got on the 22nd of this month, the TALAHour will come out. That's our monthly newsletter. If anyone's not signed up for that, go to TALAH.org, our website. You'll see a pop-up. It'll come up and you can sign up for that. You do not have to be a TALAH member to get that. And if you don't get the pop-up, then go down to the bottom of the home screen and you can see a place where you can sign up for that. And then also we have the TALAH Talks podcast that we recently launched. Helen, I know you're on. She's our director of communications. Helen, can you put in the chat? There we go. Everybody, if you want to get on we have the podcast, has an episode drop every month. Anthony Orsby Hell, who does our in-person AL managers classes, is the one doing our podcast. He is really looking at issues that you are seeing in your communities, questions that come up during our AL managers class. And it's a short segment where you can listen to that as you drive to work every day. So please check out the TALAH Talks podcast. And with that, if we don't have any questions. Oh, wait, we just got one. She wanted to know what type of juice was used in the study, if it was the cocktail or it was actual cranberry juice.
Oh, in the cranberry juice study? They were
Oh,
actually using, I'm trying to scroll through and find it right now. They were actually using tablets. They were not just using juice. It was 2 capsules for 1 year. Daily dose of 2 cranberry capsules for 1 year.
and then and that was sad, by the way, Josh, because I've always heard of that homeopathic remedy ever since, when you're younger
know.
and you hear that. And I drink cranberry juice anyway, because I love cranberry juice. So that was a little sad. I have another question for you. As an activity director, how can we advocate for this information?
That's a great question. Well, the first thing that pops to mind is, as an activity director, you can have a huge impact on at least 2 of our 3 preventative measures we focused on. Obviously, physical activity. You're probably the primary source of physical activity in a community. And secondly is hydration. Just making sure you incorporate hydration into your activity programming. But the other thing I would say, it's a good reminder. I think senior living communities are one of the best examples of an interdisciplinary approach to treating these kinds of issues. You go to a doctor's office and all you get is a doctor. Whereas in our communities, you're getting that full spectrum. So I would hope in all of our communities, an activity director is an important part of that care team. And so whatever your system is, whether you do a monthly care meeting or a weekly QA meeting or whatever, I would want to see that activities is incorporated into that and can advocate for these kinds of conversations.
Yeah. The activity part of that was that's good news.
Yeah, I mean,
Because it's something
53% reduction is a pretty shocking number, honestly. And that was just through increased physical activity.
that was great. I was really surprised by that. Right. Well, if we don't have any other questions, Josh, thank you so much. This was fantastic. I'm getting text messages about the presentation and how much I enjoyed.
My pleasure. I appreciate it
so much, everyone. Thank you for tuning in, and we hope to see you next time. Everyone, take care.